this, okay? Let's do this.
Love you.
Here we go.
In the UK, some 3 million major operations are carried out every year.
Just take some nice, big, deep breaths. I'll take good care of you.
But some patients' procedures are so complex, only the best surgeons can perform them.
We're okay to go.
Okie dokie. You do have to have resilience. We have death on our doorstep all the time.
Addenbrooke's hospital in Cambridge is world-renowned for its pioneering techniques to treat conditions that few others dare to take on.
You feeling brave?
We often deal with people at the extreme end of life. So during an operation, you're almost in the heat of battle.
But pushing the boundaries of modern medicine comes with great risk.
No margin for error here.
You have to accept that things will go wrong. Experience is learning from your mistakes.
Starting to split along where the stitches have gone in.
Every decision you make has direct consequences on someone's life.
She's not responding.
The surgeons bear the ultimate responsibility.
Oh no.
Quick, a lot of bleeding here. This is not working. What a bugger!
This is what really happens behind the closed doors of their operating theatres.
It all looks good.
Perfect. Mission accomplished.
There we go. Brilliant.
The patient is trusting you in a very difficult situation, and you just need to make sure that you deliver your part of that bargain.
On the outskirts of Cambridge is Addenbrooke's hospital, renowned for dealing with rare and unusual cancers. 5,000 patients are seen here every year and treated by some of the most skilled surgeons in the country. Like consultant neurosurgeon Alexis Joannides, who specialises in complex tumours of the brain.
I was a science person in school, and one thing that struck me about neurosurgery was combining the intellectual complexities of working with the brain, as well as the technical challenge of, doing something very precise. Certainly, the job has got very rewarding moments, but things don't always go to plan, and it does have some more challenging moments.
Alexis's next procedure is one that is so radical, it's pushing the boundaries of medical science. Operating on a patient's brain while they are awake and speaking.
An awake craniotomy is a procedure where if I was to step back and think of it as a person in everyday life, it does appear quite a surreal experience to be awake with part of your skull open.
His patient has a glioblastoma, the most aggressive form of brain cancer, which is growing near the area of the brain responsible for movement and speech.
It's important we try and do things as quickly as possible. Within a few weeks, it could lead to a sudden deterioration. An awake craniotomy will give us the best chance of making sure that we preserve these areas whilst taking out as much tumour as we can.
Alexis carries out just 15 awake craniotomies each year. It's a demanding operation, and not just for the surgeon.
Having an awake craniotomy for the patient is a very daunting, thought, and which can be very scary.
But Alexis's next patient, 63-year-old former intensive care nurse Ruth, has a different perspective.
Being awake doesn't bother me. It'd just be an experience, won't it? And I'll be watching them. I hate wasting water. I used to work in refugee camps in Sudan and never forgotten it.
Ruth started feeling ill just 1 month ago.
The first thing I noticed is that my coordination was going, and because my mother had a history of 6 strokes, I thought it was highly likely I had that.
But instead of a stroke, a scan revealed a cancerous tumour in her brain.
Well, I was diagnosed with a glioblastoma, so without treatment, I've only got 12 weeks for my demise. But at the same time, I'm a fighter, and I really believe in a positive mental attitude.
Ruth's cancer is terminal, but the surgery could extend her life by 18 months or more.
For many patients, even this amount of time makes a very big difference to their lives. But when faced with a life-limiting diagnosis, every moment counts.
Ahead of awake surgery, all patients must go through a series of tests for speech and cognitive function. Ruth's daughter, Beth, has brought her to Addenbrooke's to meet with neuropsychologist Lisa Healy, who will talk to Ruth while she's awake in theatre.
Hello, Ruth. What we do today, we'll again repeat in surgery.
Right.
My role during the surgery is to enable Alexis to resect as much of Ruth's tumour as possible, whilst crucially preserving her language functions. Secondly, I think my role is to offer an emotional support to Ruth. We'll start off, just ask me what you would call these things ordinarily in your day-to-day life, okay?
Pineapple.
Pineapple, yes.
Light bulb.
Yeah.
Recording Ruth's performance now provides a baseline to compare against how she does later in theatre.
Case. Chopping thing. This is really depressing. Oh, no. It's just really depressing. What hope have I got? But I'm going to think positive.
The tumour is already affecting different aspects of Ruth's brain function, including her speech, making the operation even more urgent.
Sounds like everything's happened so quickly and probably difficult to process everything fully, but how are you feeling about the upcoming surgery?
Yeah, it's taken my breath away.
Absolutely.
Yeah.
That's very understandable.
Yeah.
I'll be there to support you every step of the way.
The operation is Ruth's only chance to prolong her life. But the complex procedure comes with risks.
There's no clear boundary between tumour and brain. If we go too far with the resection, there is a risk of inducing an irreversible and unacceptable deficit, usually either to do with movement, sensation, and speech. One could think of it like walking a tightrope.
Ruth's tumour is in the left frontal lobe of her brain, near the motor cortex, which controls movement, and Broca's area, which is involved in the production of language. To decide how much tumour he can safely remove there, Alexis will use electrical stimulation to probe it millimetre by millimetre while Ruth is speaking. If her speech fails, he'll know that's an area he can't remove. It's the day of Ruth's surgery.
Hello.
And in preparation, she's made a decision to shave her head. Before the procedure, Ruth takes a drink containing the drug 5-aminolevulinic acid, or 5-ALA. This is absorbed by cancer cells, making a compound that glows pink under UV light. It will allow Alexis to identify as much of the cancer as possible.
Hello, Ruth. Are you ready for me?
Yes.
Good. So, you know what the procedure is, why you're doing it, the things that could go wrong, and then all the other safety checks as well. So the last but not least, I'll just draw an arrow in the correct side. And I think that's us. You're happy?
Okay. Thank you very much. Thank you very much.
No, not at all.
9 a.m. and most of Addenbrooke's 37 operating theatres are already full. In Theatre 22, a team of specialist neurosurgical staff are assembling for Ruth's procedure.
Good morning, everyone.
5-LA guided awake craniotomy for resection of left frontal tumour with electrophysiology. And we also have the psychologist for awake testing.
Okay.
And then it'll take us about 3 to 4 hours.
Right.
usual steps?
Well, bleeding, waking up, seizures.
Yeah.
Okay.
All right then.
Right.
Thank you.
Very good.
Mum, I'm right behind you, okay?
Okay. I've got complete trust in the surgeons, and I've little option, really, but to go down this road. You have to take charge of your own destiny.
It's gonna be fine. It's gonna be fine. All right, love you.
Hello again, Ruth.
Hi.
It's the job of anaesthetist Magda Smith to put Ruth to sleep, then later wake her in the middle of the operation.
I'm starting the anesthetic now. That might sting a little bit as it goes up the vein. Deep breaths in and out.
With Ruth asleep, neurophysiologist Sarah Martins attaches sensors to monitor the signals from Ruth's brain to her body. She will use these to help Alexis map the edge of the tumour, where it's infiltrating the motor cortex or movement centre.
Is this good for you?
Yes.
Right.
So the brain is a very unique organ because in many ways it makes us who we are as people. And so you need to be mindful of that, be calm and maintain control over the events that will unfold.
Okay. Happy to start?
Yes, please.
First, Alexis must cut through the scalp and 7 millimeters of skull.
Okay, let's see where we are. Okay. Rolling back to you.
Before opening the dura, the protective membrane surrounding the brain.
Once we open the skull and the dura, you are in a period of absolute concentration.
What? Can we switch off a couple of lights so we can just have a quick check?
Ruth's brain is now exposed, and Alexis is ready for his first look at the tumour under UV light.
So we've got a lot of pink there in the front.
With the cancer cells glowing bright pink, due to the 5-ALA chemical Ruth drank before surgery, he can see it's about the size of a plum.
The tumour is large, sitting in a tricky place. So we know that we need to proceed with caution.
Sort of patchy at the back.
Being a brain surgeon, there is a lot of responsibility on your shoulders. This patient is trusting you in a very difficult situation, a very vulnerable situation. And you just need to make sure that you deliver your part of that bargain.
In addition to its expertise in neurosurgery, Addenbrooke's is also one of the country's leading vascular centres. Each year it carries out over 1,200 major procedures on patients with conditions affecting their arteries and veins. Consultant vascular surgeons Simon Kreckler and Manj Gohal take on some of the most high-risk operations, procedures on the aorta, the body's largest blood vessel.
Certainly more complex cases, we may have 2 or even 3 consultant surgeons working together because it really is a team event.
Really nice to operate with a consultant colleague because it makes the whole operation more enjoyable, particularly if you get to operate with a colleague you get on with very well.
There's a harmony in the way we work. We're good friends outside the hospital, and I think that's important.
Today, they'll need their combined experience of over 40 years to perform one of their most challenging operations.
You see his aneurysm about 58 millimeters in maximum diameter.
Replacing a section of diseased aorta, the vessel connected to the heart that delivers 5 litres of blood around the body every minute. Their patient is 66-year-old Chris, whose aorta has ballooned, forming an aneurysm that could rupture and kill him at any moment.
What else do we need to put in the hospital bag?
A couple of shirts, shorts.
Chris, who lives with his wife Barbara, had a routine scan 16 years ago, which revealed he had a small aortic aneurysm, a condition more common in patients with an unhealthy lifestyle and linked to smoking and high blood pressure.
The way the doctor described it to me is if you can imagine a bicycle inner tube and it's got a weakness in that inner tube, as you apply more pressure to it, the weakness will get bigger and bigger, and eventually if you put too much pressure in it, it would burst. I would bleed out, and that would be the end of me.
In the last decade, Chris's aneurysm has continued to grow. It's now so large that the risk of it rupturing outweighs the risk of surgery.
I've been living with this time bomb for 16 years, thinking, am I going to wake up tomorrow morning?
Chris's aneurysm is in the abdominal section of the aorta. To repair it, Simon and Manj first need to cut off the blood supply to the diseased section by clamping the two iliac arteries and aorta. Next, they'll cut open the aneurysm and replace the section with a synthetic graft. But they need to operate quickly. While Chris's heart will continue to pump blood to his upper body, anything below the clamps will be without a supply. The longer Chris's legs are left without blood, the higher the risk of cell death that could result in an amputation.
If it's going to prolong my life and not end it,
Yeah.
then I'm happy to go with it. I want to grow old and grumpy.
You already are grumpy. Wouldn't be without you, though.
No?
No.
Thought of life without him. No. I don't try and think of that.
I want to spend a lot more years with him. A lot more years. And hopefully this surgery will bring us that.
The operation is high risk. Chris's diseased aorta is not only thin, but has a buildup of calcium deposits, so sewing in the graft will be even more challenging.
There is quite a lot of calcification right at that bottom end there, isn't there? So we'll have to be...
Yeah, if that's really solid, I mean, sometimes it's literally like concrete. So if it doesn't hold the stitch, we're going to be in trouble.
16 years I've been waiting for this. The bomb disposal squad are moving in. They're going to make a bit of a mess while they do it, but I'm pleased I'm here. Let's get on with it. Love you.
In Theatre 20, a team of 10 specialist vascular staff are preparing for Chris's operation.
Welcome.
Hi sir, how are you?
I'm good, thanks.
So we'll get the surgeons to join us and then we'll do our checks. Make sure you're happy with everything.
Vascular surgery can be quite unforgiving. If it goes wrong, it tends to go wrong in a fairly big way because whatever's hanging off the end of that blood vessel is typically going to die, be that a leg, a kidney, the brain or the patient.
You just start taking some really nice deep breaths. We'll look after you whilst you're asleep.
Ready for you?
Good. You guys happy? Should we start?
Yep.
First, Simon and Manj must make their way towards the aorta, buried deep in the abdomen, in front of the spine.
Have some suction, please.
So we'll just be nice and careful going into the abdomen in case the bowel wants to poke out.
Over 8 meters of small and large bowel must be carefully moved to the side to prevent any injury.
So we'll bring the small bowel towards me. We take the colon north.
Yep.
Okay, so we'll watch the long way down.
Yep.
Okay. Forceps, diathermy.
Simon uses diathermy, a cauterizing tool, to carefully cut through the retroperitoneum, a protective membrane covering the aorta.
So the centre of the aorta is just there. That's good. That's a perfect line.
Okay, I think we've got enough space there. I don't think we need to do any more dissection.
They've exposed the aneurysm, but before starting the repair, they must isolate the blood supply by clamping above and below it.
Okay, let's have the iliac clamps, please. How's that?
That's gone. That's good. Good. Right iliac's
Right
clamped.
side on.
Now they can clamp the aorta above the aneurysm.
Okay, Richard, I'm going to clamp the aorta.
The blood flow through the aorta is very fast and very torrential. So if we were to just open the aorta without putting any clamps on, within a few heartbeats, the entire circulating blood volume, which is about 5 litres in Chris's case, would come out of the body. And, that's, you would die.
Okay.
Pulse has gone. That's good. Aorta's clamped. Clip, please.
With the final clamp in place, Simon and Manj must work quickly to complete the operation.
The clock is ticking. There can be a real focus to get the graft in as quickly as possible to let the blood flow run again. The longer the lower half of the body is starved of blood, the greater the trauma to Chris's body.
Arteriotomy knife, please.
In Theatre 22, Alexis is about to start the meticulous mapping of Ruth's tumour.
Right, shall we do some cortical stimulation?
Yeah, we are all connected, Alexis.
Thank you.
Before waking Ruth, he needs to confirm where the tumour boundary meets the motor cortex, which controls movement. If Alexis removes too much, Ruth could lose the ability to move the right side of her body.
Anything that we can do safely whilst the patient is asleep, we do first. And that's really to minimize how much fatigue and discomfort the patient has.
Okay, that's the front of the tumor. Stimulating?
Yeah. No response?
The probe simulates messages from the brain to the body. The signals are only detectable if the probe is close to areas that shouldn't be removed. That way they'll know if it's safe to remove more tumour at the boundaries.
If we are in the motor cortex, we will pick up activity from these needles in the body. If there is no motor cortex in the vicinity, then we will have no response.
Now?
No response?
Now?
That's hand. It's gone now. It was very briefly, yes.
Very
that's
brief,
hand.
okay. It's as expected, really. Tumor boundary is here.
Yeah.
We also need to confirm our speech limits when Ruth is awake as well.
My senses are guided by the rest of the team. So in a way, you could think of them as the eyes and ears. Without that, you would effectively be operating blind.
The tumour boundary with the motor cortex has been established. Alexis is now ready for the most unpredictable part of the operation. Waking Ruth.
I think we could probably start waking up.
Okay.
And now we wait.
Anaesthetist Magda slowly reduces and then stops the sedation. When Ruth wakes up, she won't feel Alexis removing the tumour, as the brain has no pain receptors.
The transition from being asleep to awake sometimes can be unpredictable.
We just need to wait until she wakes up and make sure that the brain doesn't swell out.
By waking up, the brain is more active and will generally swell more than when it's asleep. So we need to make sure that we're prepared for dealing with that.
The chance of swelling is even higher, as the large tumour is pressing on Ruth's brain.
Have a bit of swelling. It is a worrying scenario. In the most extreme of situations, there is a possibility that it could herniate out or mushroom out of the opening we've done in the dura and even rupture at the surface. That could lead to permanent damage that is irreversible.
Magda, can I go slightly head up? We're just a tiny bit swollen.
Let's see.
To stop the swelling, Magda raises Ruth's head which relieves the buildup of pressure. In addition, Alexis gently pushes on the brain to prevent it expanding any further.
One of the abilities that a brain surgeon needs to have is to remain calm and contained under pressure, to make sure that they have control of the situation.
Okay, that's good.
Alexis gets the swelling under control just before Ruth is fully awake.
Hello, Ruth. Open your mouth wide. Well done. Perfect. It's all fine, Ruth. Just waking up. Need you to take a deep breath in and out. That's good. Very good. Hold my hand here.
From the patient's perspective, you wake up in the operating theatre, your head is fixed, your brain is open to the air. I think it would be very frightening.
It's a little bit different waking up from anesthetic than it is from a normal sleep.
Yes.
Yeah. So the surgeon has already started the surgery, but we're now at the point that we're gonna do the testing on your brain.
Yes.
Okay.
Yes, thank you.
Now Ruth is awake, it's neuropsychologist Lisa's job to retest Ruth's cognitive function whilst keeping her calm and speaking.
Hello, Lisa.
Hello, Ruth. Lovely to see you. How are you doing, Ruth? You okay?
Yes.
You're okay, yeah? It's a vital part of my job to reassure Ruth and monitor how she's feeling. It's a huge thing to be woken up during the middle of brain surgery.
I've never had so many people wake me up.
Yes, I bet you haven't.
Alexis, Lisa and Ruth now need to work together to map where the tumour meets the speech area of her brain.
So, whenever you're ready, we'll just do some stimulation.
Right, no problem. Here we go. Okay, we'll do some counting for me. Okay?
Right.
So we're going to start from 1 for me.
Right.
Okay, here we go. 1.
2.
Good, keep going.
3.
If Ruth is speaking fluently, Alexis knows the area he's stimulating is not directly involved with her speech centre and can be safely removed.
Yeah. Keep going. Well done, Ruth.
We're doing 3 types of tests with Ruth's speech. Each one of them is looking at a slightly different aspect of speech, which is in turn controlled by a slightly different area of the brain.
If you could open your eyes for me, Ruth.
In the next test, Ruth must identify objects on Lisa's screen to check Ruth's ability to select the correct word and convey it through speech.
Okay, what's this?
Sash window.
Great. Brilliant. Keep going for me.
Pineapple.
Yes.
Basket.
Basket. Good.
Livre. I mean, but
Semantic error, Alexis. When Ruth makes a speech error, it's an indication that Alexis is touching an area that's important for language function, and he may need to preserve that area. Okay, now I'm going to say some words, and I just want you to repeat them back to me, okay? Statistician.
Statistician.
Stethoscope.
Stethoscope.
And then the last one is chrysanthemum.
Chrysanthemum.
Brilliant, well done.
Alexis now has a clear idea of where the tumour ends and the healthy tissue of the speech centre begins.
Can we just dim the lights down a bit?
Alexis is just dimming the lights now.
3 hours into the operation, and with the boundaries established, Alexis can start to remove the tumour. Under UV light, the cancer cells are now glowing bright pink from the 5 ALA chemicals. Using a microscope that magnifies up to 20 times, Alexis can be exact and only remove the unhealthy tissue.
You all right, Ruth?
Yes. You are all wonderful.
Starting to see more normal brain now.
With the centre of the tumour removed, Alexis can turn his attention to the more difficult margins, where diseased and healthy cells are interspersed and the risk of removing functioning tissue is high.
It can become tricky to decide how much further you want to push that boundary.
Happy, Sarah?
Yes.
Sarah watches for any unusual brain activity that might indicate Alexis is in an area related to movement.
You keep edging closer and closer, and at some point you decide that the additional risk may not worth the benefit.
What are you trying to tell me, Ruth? Say again?
But just as Alexis is making significant progress,
Take your time. What are you trying to say?
1.
Ruth's behavior changes.
She's counting spontaneously, Alexis.
What?
She's started counting spontaneously. Yeah.
Are we okay now?
Yeah, she's generating something, Alexis.
We clearly know that something's not right. I've not seen this particular reaction before in surgery. It could be any number of things.
Suddenly, Ruth stops talking altogether.
Can you stop for a moment, Alexis?
Yeah, she's not responding, Alexis.
Alexis, can you stop for a moment? You're having trouble with the words. It's all right.
It is very scary when a patient stops speaking out of nowhere in theatre, and we just need to find out why.
Can she say anything? What about just spontaneous speech?
Hi, Ruth, it's Lisa. Can you say my name, Lisa?
Any operation you undertake in the brain has got a small chance of going disastrously wrong.
Nothing, Alexis.
Nothing.
Nothing.
The worry is that it caused some form of permanent damage.
No, this is the hard part, isn't it, Ruth? I'm right here, okay?
The brain is one of the most remarkable organs, defining who we are as human beings. Yet very little is known about what happens to the brain when it becomes diseased. One department in Addenbrooke's that is on the front line searching for answers is the Cambridge Brain Bank.
Cambridge Brain Bank is a resource for researchers to use where people donate their brains when they die and provide tissue for researchers looking into diseases such as Alzheimer's disease and Parkinson's disease.
The team at Addenbrooke's belong to an important network of 146 brain banks worldwide. Here, they store 1,500 brains for scientists across the world to access. Each week, they receive a new donation.
The brains arrive fresh, usually on ice, having just been removed in a mortuary.
An adult brain weighs nearly 1.5 kilos and contains around 86 billion neurons, the cells responsible for receiving and transmitting information around the brain and body. Kieran prepares the brain in 2 ways so that multiple samples can be made for different types of research.
So this is the brain of a person who died suffering from an incurable neurodegenerative disease.
One half of the brain is cut into 5mm thick slices and then rapidly frozen at -80 degrees on a bed of dry ice.
The freezing process preserves all the parts of the cells of the brain, so all the DNA, the RNA, the proteins, etc., that researchers might be interested in the future.
These samples can be used to analyze how genetic conditions develop in the brain, like Huntington's disease. The other half of the brain is soaked in formalin, dilute formaldehyde, enabling the samples to be studied for several decades. It also preserves the structure of the tissue and means diseases like dementia, which causes a loss of brain volume, can be microscopically examined.
In my lab, we are studying the underlying processes of a group of dementias by identifying markers that are associated with disease in the tissue. And hopefully, this will lead to new treatments.
Dementia is the leading cause of death in the UK, with numbers increasing each year. The important work of brain banks could provide a vital lifeline to those facing a diagnosis in the future. With the continued support from donors, researchers can move closer to unlocking the secrets of brain disease and developing potential new treatments.
It's a great privilege to examine the brain tissue of people who've donated their brain to science. And it's a very generous donation. It's a donation that will help people in the future. It's a donation to science, to humanity, really. And I'm always very conscious of that and very grateful for that.
In Theatre 20, vascular surgeons Simon and Mange are working against the clock to repair Chris's aneurysm. With the vessel clamped, they have reached a critical point and must now cut open the aorta.
Suction to me, thanks.
Once you've opened the artery, that is the point of no return. Simply abandoning at that point and giving up is not an option. So we have to repair the artery one way or another.
You start up there somewhere, that should be a good place.
Ready?
Yeah.
With the aorta now open, blood that's collected in the aneurysm is suctioned out.
The spinal bit comes out perfect. So.
Yes, ditto.
With no blood flowing into Chris's lower body, Simon and Mange need to operate quickly. The longer it takes, the higher the risk of dangerous clots forming in his legs that could cause cell death and lead to an amputation.
Let's get the top end on first. So let's see the graft, please.
Graft, please.
To repair the vessel, Simon and Mange will stitch in a 7-centimetre graft into the top of Chris's aorta. To test the joint is watertight, they'll open the top clamp, allowing blood to flow into the graft. Then, they can stitch the graft to the bottom end of the aorta to complete the repair. Next, they'll open the clamps, restoring blood flow to Chris's legs. Finally, the section of aorta will be sewn up around the graft to help prevent infection.
You happy?
We are happy.
We're happy.
Simon and Mange are ready to start stitching the top end of the graft into the aorta. Made from woven polyester, the structure of the graft is flexible and resistant to stretching.
I wonder whether we start over there and get those first 2 or 3 in.
The connection needs to be watertight. When the clamps are released and blood flows through the graft, any gaps in the joint could cause a catastrophic bleed.
You're relying on the aorta being of suitable strength to be able to take your stitches, to be able to sew a graft into, and it's a bit of an act of faith.
There is your
line at the top.
Line at the top.
Okay.
But ultimately, until you physically put the stitches in, you don't know how well they're going to hold or how strong the aorta is going to be.
So a nice deep one into the back of the aorta here. Just careful with that curve. Yeah, very nice. Okay. Can I have a clip, please? We need to pull that graft right inside.
With the stitches in place, Simon and Mange need to pull the graft tight against the aorta.
Okay, you ready?
Yeah. So that's looking nice, it's balancing up nicely. So now that we've sewn the graft into the top end, in a moment we'll have to let the blood flow in again to see if it's watertight. We're just going to test the top end in a moment, guys, just in case there's some bleeding. Not anticipating too much drama, but just to let you know.
Okay, Raytech, please.
To test their connection, Simon places another clamp in the middle of the graft so he can open the top clamp and allow blood to flow from the heart into the graft.
You happy? Oh, sorry.
Yeah, can I put that back on for a minute, son?
Just looks a bit like aorta giving way to me.
Let's have a look.
Got a bit cheese wiring.
The stitches are tearing through the aorta because Chris's tissue has become thin and weak due to disease. If they don't hold, Simon and Manj will have to reinforce the aorta, adding time to the operation.
Working with a consultant colleague like Manj means that you know that if you run into problems, you've got that immediate backup.
You're not dealing with potentially challenging, difficult situations on your own, and actually having that extra pair of eyes and experienced hands, that's worth gold, really.
Let's see if we can see it with this. Are you ready?
To identify where the leak is, Manj injects saline into the graft.
Did you see where it was?
Yes, it's coming out the side there.
It's starting to split along where the stitches have gone in.
That splits again, quite round posterior.
The aorta is tearing. It must be reinforced for the stitches to hold.
Have you got a Teflon pledget, please?
Yeah.
To do this, Simon and Manj will use pledgets, 2mm discs of synthetic fabric, which they will stitch into the aortic wall to support it.
It's better. Should put that clamp back on, and should we just have a gentle test again?
Suction.
Thanks.
No, still good.
The first pledget isn't working.
That's always a bit of a heart sink moment, and your little, levels of anxiety raise because you start to think about, what are we going to do next?
Coming from under the pledget. Here's a split there. Oh, there. That stitch is splitting. I think that one there is splitting.
There's sort of a saying, a surgeon in the hospital has a problem with bleeding, they'll call a vascular surgeon, but when a vascular surgeon's got a problem with bleeding, who are you going to call?
If the aorta continues to tear, Simon and Manj will have to open the aorta even higher to try and join the graft further up. A much more extensive procedure, with no guarantee the aorta will be any stronger.
The risk of major complication or death is somewhere in the region of 5%. 95% of the patients are okay, but by definition there will be people that fall into that 5% who have a major complication, and it is devastating, both for the patient and the surgeon. And you do start to worry about what may happen if you can't get yourself out of this problem.
The aorta itself isn't as good quality as we thought.
No, that looks a bit ropey, that bit there.
As many of the morning procedures in Addenbrooke's are wrapping up, in Theatre 22, the operation to remove Ruth's brain tumour has come to a standstill, as she has suddenly stopped speaking.
Will you try to do some counting for me, Ruth? Okay, starting with 1. Will you try and do some counting? 1. 1. No, she's gesturing, Alexis, but she's not counting. My primary goal is to ensure that her speech and language functions are maintained. Now, at this point, Ruth not being able to speak, it's very upsetting.
No evidence of seizures, is it?
I don't think it's a seizure.
I don't think so.
Sarah, have you got any seizure?
All is fine here.
We'll just let things relax a bit. Hello, Ruth. How are you feeling? Are you able to say anything for me or not? Not at the moment. All right. Fine. Good. Fear is your enemy in theatre only if you let it get the better of you. It is worrying, but you realign what you're doing and you go through things systematically. So the first thing you can check is all the technical factors. Working very much towards the hand area. I wouldn't have expected any speech where we were working at.
The neuropsychology didn't report many errors, so it was very sudden.
I don't know, but the speech is gone.
It's very hard to remain calm because you second guess everything that you're doing. Why is this happening?
We've not had any vascular issues.
At least none that I can detect.
Right, so no vascular, okay. It still doesn't explain why I've lost
speech.
I'm replaying everything that has occurred in surgery up to that point in my head, every step that we have taken, every test that we've completed.
All the areas stimulated around didn't
Yeah.
have any speech arrest.
Yeah, no.
So,
And on the object name, there's only one that she just missed, but then the ones afterwards she got.
yeah, okay. We didn't see any major vessels either, so...
Yeah.
The way Ruth changed is not usually typical if things go wrong. It is a worrying scenario. We've achieved a good resection, but given the uncertainty of pushing forwards, I have to make the decision that we should stop resection there and then wrap the operation up.
With Ruth not speaking, it's too dangerous for Alexis to continue removing brain tissue. Fortunately, he's removed most of the tumour.
I'm gonna give you a bit of a sedation, Ruth. You don't have to do any more testing.
Are you comfortable now, Ruth?
You comfortable, Ruth? Yeah, she's gesturing yes, thumbs up.
Okay, good.
After closing the dura and screwing in place the window of skull,
We're almost done.
Alexis carefully stitches Ruth's scalp together.
Almost there, Ruth.
Okay.
After over 5 hours of intense surgery, Ruth's operation is over. But she's still not speaking.
Ruth, we're just taking you to recovery.
But at this point, we don't know how things will evolve. And the worry is that you have caused permanent damage to Ruth's speech.
In Theatre 20, Simon and Mange are struggling to attach the graft to Chris's diseased aorta as their stitches are tearing through the weakened blood vessel.
So do you think we need to go further back or further up with the
Well,
next?
the concern I've got is each time we're cramping down these stitches, it's just cheese wiring through the aorta.
That's probably one of the most awful situations to be in because there's very little you can do. I've had one case where the patient died because we weren't able to stop the bleeding from the aorta.
Let's have the pledget, please.
Yep, pledget.
Mange decides to double the layer of pledgets, the minute pieces of synthetic material, to strengthen the section of aorta that's tearing.
2 different pledgets actually, yeah, so let's pull that one through.
What we want to do is to put a pledget on either side of that slit.
Another pledget, please.
When the stitch is then tied shut and tied tight, the 2 pledgets can then squash that weakened and slit aorta to close off the hole.
There is a potential that the pledgets may not work.
Not tightening it really hard. Okay, let's put the rubber shot on there for a moment, thanks. Shot, please.
With a second layer of pledgets attached, Simon and Mange need to test their holding and have created a watertight seal.
So what do you just gently let it off a couple of clicks. Okay, I'm going to come away very gently now.
Looks better.
Okay,
good.
Fantastic.
Finally, the pledgets have worked and the stitches are no longer tearing through Chris's aorta.
There is a lot of relief because then it means we can move on to the next part of the operation, which can be equally or more difficult.
We're now going to start looking at the bottom end.
Though they've solved the problem at the top, they still have to secure the bottom, and the clock is ticking. Each minute that Chris's lower body is without blood increases the risk of dangerous clots forming in his legs.
How far off reperfusion do you think you are?
The bottom we think might be harder than the top, so probably about 45 minutes away.
Thank you.
They inspect the bottom of the aorta, where the other end of the graft must be attached.
Oh gosh, that is very calcified, isn't it? Oh, crunch. So I can really feel the calcium in the wall of the aorta. Wowzers.
Did you just say wowzers?
I did, yeah.
They discover the calcium deposits they saw on the scans are much worse than expected.
There's a proper little pavement slab there, isn't there?
Calcium is the vascular surgeon's worst enemy when it comes to trying to repair arteries.
I'm going to go in to out on graft. Okay, it's not going to work backwards.
No, reverse, yeah. Oh, it's all calcified here as well. Oh, man. Come on. That's not going to come through, I don't think.
Aortic surgery involves a lot of fairly high-level decision-making. We bounce ideas off each other and we support each other.
I could fracture it.
Yep, you fracture that bit there, that'd be useful.
Simon and Mange must break up the calcium to create gaps to place their stitches.
Okay, stop there. Let me see if I can come through this bit here. Little gap there now.
Yeah, okay.
That's good. That's a nice stitch. Let's just pull that graft right into. Yep. Lovely. Yep, that's good.
They've successfully secured the stitches in the tiny spaces between the shards of calcium. Now the graft is attached at both ends. But the clock is still ticking. Chris's legs have been starved of blood for nearly an hour and a half, meaning dangerous clots may have formed. Simon and Mange must now restore the blood flow by releasing the clamp at the top of the aorta and the clamps on the iliac arteries, which carry blood to the legs.
You press on your groin first, we'll let your side go, and then I'll control it from the aorta.
Yep. This is the critical part of the operation. This is where we'll know if we've been successful or not.
So can we turn the monitor so we can see it?
Of course. When we release the clamp, what we want to see is a drop in his blood pressure, which shows that the blood is flowing into this space where it wasn't before.
If Chris's blood pressure doesn't drop, it could mean clots have formed and blood can't get through to his legs.
Let's gently reperfuse and see. We've got total inflow control.
You guys ready?
Yeah.
Yes.
So we're just taking the clamp off there. Okay, left leg reperfused.
Is that dropping?
A little.
Now the anxiety is when we release the clamp, nothing happens. And that means that there's now a blockage in the iliac artery, something's clotted off, so we've now got a new problem we have to deal with.
And did it drop again?
Yeah, a little bit, yeah.
Okay.
All right, so we're completely off.
There are 91.87. Yeah, that's a nice drop.
Good pulse in the groin.
Good.
That's reassuring.
We're in a nice place, so I'm happy.
So once we've seen that pressure drop, we know you've got flow back to the leg. You know you've done the job you set out to do. And the clock has now stopped ticking.
Blood is now flowing into Chris's legs, meaning no clots have developed during the operation.
We're going to start closing, Richard.
Perfect.
Simon and Mange can now stitch up the aorta around the graft to help protect it from infection.
At the end of a successful operation, there's obviously relief that we've achieved what we technically set out to achieve, but actually that's only the start of Chris's journey.
Home straight.
But once he gets there, it will mean that the potential problem that could rupture at any point has now gone, and I think that should be a big relief for him.
Hello, Christopher. So open your mouth. Here we go. Don't worry.
Nice deep breaths. Deep breaths. Thank you.
day.
Lovely.
Within days of having surgery, Chris was back home, making a quick recovery.
We got home a week after surgery, and the next day he was out walking up the road. So proud of him.
Lovely to get out there on my bike and just carefree riding, knowing that this isn't going to rupture on me and I'm going to make it home again. It's made me realise how valuable life is. There's such a fine line between life and death. And I'm just grateful that I'm on the right side of the line.
It's been 10 days since Ruth's awake surgery, where she suddenly lost the ability to speak. Today, she's returned to Addenbrooke's to see Alexis.
The worst case scenario that we all worried about is Ruth's complete loss of speech. Just through here. Right, take a seat. So Ruth, out of interest, do you remember the operation?
I remember, I've no memory.
That's fine. So now it's a great relief to see that Ruth is speaking.
Day by day, Ruth's speech is improving, and she's set to make a full speech recovery in the coming months.
So in retrospect, we know that the tumor was involving part of the SMA, which is the area just in front of the motor cortex. And in some people, it can affect the production of speech. And the good thing about it is it usually recovers between days and weeks. And
Really?
we're sort of seeing that already. So, the scans. This scan is before the surgery. There's the tumor there, the bit in white. And this is the scan after the surgery. All the white bits have gone.
Wonderful.
So the journey from here, the average prognosis of survival is about 16 to 18 months.
Yes.
And that said, some people will go on for a year, 2 years, with no evidence of a tumor.
Well, I've got lots of goals. Up to 2 years. For Beth to graduate, I've got positive goals. Yeah.
Knowing Ruth and her determination, I'm hopeful that she will be able to make the most of the extra time that the surgery has been able to provide her.
You've saved my arse.
I mean, you did.
Wrong part of the body, but yeah. What we're offering is the opportunity for a patient to make every moment count. And knowing that you've been able to provide this opportunity to an individual makes the whole process and the risks attached to it worthwhile. Bye-bye, Ruth. Bye-bye.
Next time,
He's literally doing this just for me.
a husband donates his kidney to his wife.
Scissors, please.
2 complex operations where success is not guaranteed.
But she's highly irritable.
My greatest concern is that her heart will stop beating.